We will introduce Dr. Anjana. Of course, the CV is there for visualizing, but a dear friend, a clinician, a superb clinician, and a very avid researcher. Also, very dedicated daughter, wife, and mother is what I think is something that sets her apart, and a very, very dear friend. So with this, I introduce the Managing Director and Diabetologist of Dr. Mohan's Diabetes Specialty Center and the Vice President of Madras Research Foundation in Chennai. So over to you, Anjana, for your talk.
Thank you. Thank you so very much, ma'am. At the outset, I'd like to especially thank Neeta ma'am for giving me this opportunity. This is the new fad, the new trend in diabetes care, right? So let me just share my screen. Just 1 second. Yeah, can you see this? I'm making it full screen. Has this come? Can everyone see it?
Yes, we can.
Yes.
We can.
So I'm going to start by thanking Neeta ma'am, Sanjay Agarwal sir, the chairpersons, everyone. Like I said, all my favorite people at the same time on the same screen. I'm a happy person today. So thank you for giving me this opportunity to talk about reversal of diabetes and the nutritional reversal. So whether very low calorie diet or low carb diet fares well in this scenario. So let me just try and get rid of that. Okay, right. So when you look at the natural history of diabetes, okay, we always talk about NGT, pre-diabetes, diabetes, and complications. And so far, we've always talked about getting A1Cs under control so that we can prevent the complication risk. But today, we're going to change focus a little bit and go the opposite direction, where we go from diabetes to pre-diabetes and all the way back to normal, the condition which we call remission. Now, there are lots of terms that people use. People talk about remission, they talk about cure, reversal, a whole lot of things. So what do these mean? So the recent consensus guideline that has come from ADA, and also just recently, there's a consensus of all kind of consortiums, which talk about using the term remission as the right term for this kind of reversal from diabetes to normal. And why that is so is because although the person is no longer active having disease, there is always a risk of going back to that state. And thus, they borrowed this from oncology, I think, where the term remission is what needs to be used, and that's supposed to be the correct terminology. So there are many definitions for remission, but let's go with what the ADA says. They have three sections to this. So what they define as partial remission is defined as an A1C of less than 6.5 and or a fasting glucose of 100 to 125 for a period of 1 year without diabetes medications. Then when you go to complete, now this is going all the way to normal. So A1C less than 5.6, fasting glucose less than 100, again for 1 year with no diabetes medication. And what is prolonged remission? The same complete remission for a period of 5 years or longer. So these are the definitions of remission. There's one more terminology that we should look at, and that is mitigation. So what is that? That is euglycemia that may occur due to a low carbohydrate diet without weight loss, which does not meet some of the definitions of remission. So there's also one more term, which is mitigation. Right. So when we're talking about low carbohydrate versus low calorie, let's first find out what these are. Just to put this in context, the average Asian Indian diet has about 60 to 70% carbohydrate in its diet. So all of these are high carbohydrate, about 45%. When you say moderate, it's 26 to 44. And low carbohydrate is defined as less than 26% of carbohydrate coming from your diet. And very low carbohydrate is less than 10%. Really hard to do. Now, what is very low calorie diet? This is calories less than 800 calories. And again, to put it in context, the average Asian Indian woman eats about 2,100 calories, whereas the man is eating 2,200 calories. So again, putting that in context of what a very low calorie diet is. Now, what does the evidence say? Now, what I've done here is I've kind of tabulated all the evidence that we have, on all the low calorie as well as the low carb diets. And this is a very comprehensive but long list, but we're not going to go into this. What I'm going to do is going to take you through the story of how this evolved. And the first study that came was called the Counterpoint study. Now, this was a group that was based in UK and Roy Taylor's group, this is. They started off by taking 11 people. So most of them were male. These These were obese type 2 diabetes and put them on a 600 calorie liquid diet. So what they did, this is a replacement, a meal replacement. Only 600 calories was allowed in the whole day, and they had measurements at 1 week, 4 weeks, and 8 weeks. They looked at the basal glucose output, other than, of course, weight loss, BMI, and fat loss and all. They also looked at hepatic glucose output, hepatic and peripheral insulin sensitivity, and the beta cell function. Along with, they used magnetic resonance imaging to look at pancreatic and liver fat. And then they kind of matched this with 8 non-diabetic participants. So these were their results. So as you can see here, right in 1 week, so this is fasting plasma glucose. You can see just in 1 week, it normalized to the normal range. The red is the normal. It came all the way almost to normal range. Similarly, with A1C over time, it almost touched normal. So in this 8-week period, they were able to show remission of diabetes. Now, what happened inside the liver? Look at the fat percentage. So the red line is where the controls are. So this shows you that clearly it's going within 8-week period well below. The liver fat is kind of almost melted. So the insulin sensitivity index beautifully raises. And even in the pancreas, look at the fat level. It's reached the level of normal. And the first phase, the insulin secretion has picked up beautifully. So the one that's getting altered, and we'll talk about that a little later, is the first phase insulin secretion. And just to put this in context, this can be done by even 0.5 grams of fat that is seen in the pancreas. So what they showed here was that normalization of both beta cell function and hepatic insulin sensitivity in a type 2 diabetic patient was possible through energy restriction alone. So the thing is that, see, when we talk about this in context, remember we were talking about the type 2 diabetes coming only when there's 80% loss of the beta cell. It's irreversible, moves in one direction. So I think this is what they have countered by showing that it is possible to reverse. And this was particularly associated with weight loss and decrease of fat in the liver as well as the pancreas. So that was the counterpoint. Now the same group went on to do the counterbalance. Now what did they do? They showed that reversibility is possible. So they wanted to know in whom it's reversible. They took 2 groups of people, diabetes with duration less than 4 years and long duration more than 8 years. Again, small numbers, 29 people only. They did the same 600 calorie liquid replacement diet. I must add, there was also a big vegetable component that went into this and plenty of water, at least 2 liters per day. And they started doing the assessments. So here the difference is that, so like I told you, there were 2 groups, those with diabetes less than 4 and more than 8 years. They did the 8-week, same as Counterpoint, same thing they did. Then they did a 2-week isocaloric return to normal eating. Now they say return to normal eating. Now what does that mean? They made liquid into solid. But is it normal? No, it's not, because it's still 800 calories. So the calorie is still low. It's actually less than 600 calories. And then they go into a weight maintenance period again, where solid eating is allowed, but the calorie is still very low, still in that very low calorie thing. So this is the counterbalance protocol. Now, what happened to weight? So look at weight. This is for short duration versus long duration. Short duration is green and long duration is pink. They're about the same. Everybody lost weight. Mean weight loss is about 15 kilos in weight loss. Tremendous weight loss, equal among the groups. Now, let's look at what happened to glucose levels. Here, you'll see the huge difference between the groups. So short duration, less than 4 years, beautifully the sugars normalized and came to the normal. Now, in the long duration, more than 8 years, there were kind of 3 groups. The first group nicely came down, behaved like the short duration. So there are some people for whom it came down. Then there was the next group which came down but took time. Within 1 week, there was no response. Slowly over 8 weeks, it came down. And the last group is the flat group here. Whatever you do, it doesn't come down at all. The minute you let go of that liquid and it changed to solid, the sugars kind of don't come down at all. So here they concluded that in people with type 2 diabetes with more than 8 years, long duration, about 50% chance of achieving remission. So in short duration possible, long duration 50%. Now let's look at another question that they were asking. What is the durability? So first they showed the feasibility, then they showed in whom. Now they're looking at durability. For a 6-month period, is this sustainable? And these were the results. So shown here, so to read this, first let's look at C. This is weight. So this is the first period in time. So dramatic weight loss, first 8 weeks. That little shaded zone there is the 2 weeks where they shift from liquid to solid, and then is the maintenance. Look at the weight, whether it is 4 years, 8 years, whatever it is, weight loss was profound and stayed the entire period. Because remember that the calorie is still quite low throughout. But now let's look at glucose. Now here you have 2 groups, the responders and the non-responders. So the responders are the dark dotted lines. Clearly the sugar came down. This is A1C. Both are behaving similarly. It comes down and then stays down into remission. So these are the people who have managed the remission. But there is a group of non-responders who come down. But the minute you stop that liquid restriction, even if the calorie is low, it goes into solid, the sugar goes up and stays up. So the A1C has not come down at all. And these people were defined as non-responders. Now, just to look at, sorry about the busy slide, you needn't worry about it. I'll just tell you quickly what it is, just to show you the difference between the responders and the non-responders at 6 months. The responders, they had beautiful weight reduction. The BMI, the fat mass was lower in these people, even at baseline, came down beautifully. The insulin responded very well. The hepatic glucose output was lower. The visceral fat was lower and the subcutaneous fat was higher. Blood pressure was lower. So these people are a younger, kind of more new onset diabetes, newer compared to the non-responders who had all the ulta. So weight came down, but they had the fat mass, which was higher. The visceral fat wouldn't come down so much. Insulin didn't come down. Hepatic glucose output wouldn't come down. So these are a group, right in that first few weeks, you can make out who is responding versus who is not. So here they showed, so CounterBalance showed that remission was possible in 40%. Now, you need to take this into context. This is, first of all, it's 29 people, 29, 30 people. That's a very small group. This is done. This is not the general Janta type 2 diabetes that we're treating. They're a particularly targeted, motivated population in a clinical trial. And in that trial, we are saying that 40% are remitting. So there is a group of people who you can remit, and there are particular characteristics of those who respond, which I talked about before. And this is sustained. For someone who is remitting, it is possible to sustain for 6 months. So these are the first main studies. Then we move on to direct. Now, this is another UK-based studies. The number is slightly larger here. They almost did 300 people. Again, obese type 2 diabetic. And again, it was a formula diet around 800 calories. So what they showed here, similar to Counterpoint, CounterBalance, 46% of the participants in the intervention group achieved remission. And this was sustained at 12 months in the sense that 24% of the participants were able to sustain. But the important point here is that it was linked to that 15 kg weight loss. So those who lost weight were able to continue the remission. They also showed here quality of life, as you would expect, improved dramatically when someone remitted from diabetes. So these are some of the figures that come from direct. Now, just to show you what this means, the first panel A here is about those people who achieved that 15 kg weight loss. Among controls, almost very small percentage reached it. In intervention, in first year, 24% only reached that 15 kg loss. And by second year, a lot of them had come back and that came down to 11%. Who reached remission? In the intervention group, 45% achieved remission. Year 2, it fell to 35%. So the last one is on how the remission happens with weight loss. So for those who lose less than 5 kilos in weight, remission very small, 5%. When it goes to up to 5 to 10 kg, 33-20, about 30% remission. When it goes to 15 kg, then you're talking about 50-60% remission. More than 15 kg, huge amounts of remission, which is sustained even in the second year. 86 became 70%. These are very fantastical figures that you're seeing. But again, this is a clinical trial. People are on liquid replacement. This is a targeted population. So the take-home points here was that for those with short duration diabetes, so that's the other thing, all these were short duration with a huge weight loss, they were able to sustain this remission even at 12 and 24 months. So those were all the Caucasian kind of studies. Now this is Anjali Bhatt's study, which was done right here in India. And she's able to study 12 people, again, obese type 2 diabetes. And here she did a low calorie, not a very low calorie, but a 1000 kilocalorie diet, which had about 46% carbohydrate. So again, here she saw in her group, about 50% of people were remitters or responders, and the other 50% was not responding. Now, what she showed was that everybody came down, the sugar came down, even in the non-responders, the sugar came down. Only thing, it did not meet the remission criteria. That's all. 50% of their participants had, in the non-diabetic range, they were able to stop their medication and were in clinical remission. The responders were younger, had shorter duration of diabetes, and needed less treatment at the beginning itself. There was also a significant reduction in the liver transaminases in the responders, whereas the non-responders, as we saw before, had higher levels of insulin resistance, less beta cell capacity, secretory capacity, and less insulin sensitivity even at baseline. So we've so long talked about all about the very low calorie diets, and all of these work on the twin cycle hypothesis. So I've been stressing so far that everything is related to weight and how does it work, the body fat. So a positive calorie balance, excess calories over time, you start accumulating liver fat. Now there's insulin resistance that's happening. There's also VLDL being shunted out. This then moves on to the pancreas. Pancreatic fat is accumulating, and once pancreatic fat accumulates, like I told you, even 0.5 grams of fat can prevent insulin release. So there's inflammation, there is overstimulation of ATP. So what happens is that when glucose comes from outside, the insulin release is dulled, and the first phase insulin response is lost. So this is the cycle that we're reversing. So when you lose weight, the fat in the liver goes away, fat in the pancreas goes away, and all of this can be reversed. The first phase insulin secretion thus picks up. So it's working on these hypotheses. Now let's move on to low carbohydrate diets. So now these diets are, again, these have been longer in existence than the low calorie diets. So right from Shashita Charaka and all of these people for diabetes, restricting ketogenic diets, they were doing it not just for diabetes, but putting a patient onto a low carb for epilepsy was very common in times gone by. So I have a meta-analysis here of the effect of the low carbohydrate diet on weight. And this is data from 14 RCTs. And of course, you do have a tremendous weight loss with the low carbohydrate diet, with also a decrease in fat mass when compared. So there are many ways this is being done. Low carbohydrate diet compared to normals, which is just traditional control of in the diabetes, the traditional treatment, or they've compared the low carbohydrate with the low fat, and they're able to show even more than the low fat, there is a reduction in the fat mass, which has durability up to 12 months or so. Now, what about diabetes? Again, this is systematic review and meta-analyses. Again, these are, first one is 9 studies, and here they've looked at, so 700-ish. So the numbers here are more, there are more studies here, which have shown there's a significant reduction in A1C with the LCD group. There's reduction in triglyceride, body weight, etc. And the difference between this and the previous one is that all of the euglycemia happens with less body weight reduction as compared to the very low calorie diet. There, everything is being driven by the body weight and the fat. Here, the euglycemia happens separately with or without loss in body weight and fat. Again, we have some RCTs here. Here, there was a short-term improvement in insulin sensitivity, glycemic control, lipid profile, once you decrease the carbohydrate intake. But this is the largest study that we have as of date. It's 1,350 patients, meta-analyses of all low carbohydrate diets. And they say that a higher rate of remission is achieved. So it's very similar, 40-50% from low carbohydrate diets. There's improvement in weight and loss, that is, and insulin sensitivity and triglyceride, and there's data up to 12 months or so. So this is quite similar, the only difference between the two being the weight loss. Now, here is a study that has compared head-to-head on whether the low-calorie diet or the low-carbohydrate diet is doing better. 84 individuals were studied here. They're all obese, type 2 diabetes, all young onset of diabetes. And what they did is, so the ketogenic diet, that is the low-carb one, and the low glycemic is the low-calorie. They gave only less than 500 calories they have given. for 24 weeks. And these are the results. So the low calorie one, so I keep getting confused. The GID is the calorie, right? So the first one is the low calorie one, and this is the low carb. The second panel is the low carb. So what they show here is that the A1C came down. In fact, in this particular study, the low carb diet performed better than the low calorie diet. It brought down A1C, brought down fasting glucose, insulin, BMI, even body weight. Actually, they did better, which is in contradistinction to other studies which have shown that the low calorie diet has modest weight reduction. But in this particular study, they concluded that the low carb diet was actually better. So they said both work, okay, and both cause all of these good things to happen, with the low carb diet being more effective. However, in patients taking insulin, the effects, you have to be a little careful. So that's what they concluded. Now, what is this working on? This is working on the principle of low carbohydrate. There are two main things that happen when you do low carbohydrate. So first is that because of the lack of carbohydrate, your insulin, plasma insulin, hyperinsulinemia comes down, the glycogen storage goes up, gluconeogenesis happens. That's one thing. The second thing that will happen is that because there's lack of energy, lipolysis takes place and ketogenesis results. So this is the main thing by which the low carb is working. However, there have been potential safety concerns with the low carb diet, and there are many that are listed in this publication. Nutritional deficiencies. Now, what happens is when you kind of reduce carbohydrate, automatically you increase the fat or the protein. And there is a huge deficiency of fiber, which has been linked to excess mortality. There's also things on bone health, renal calculi, hypoglycemia. If in a diabetic, you don't stop all the medications, that can be a problem. Ketosis, which can manifest as vomiting, diarrhea, gastrointestinal reflux, nephrolithiasis, ketoacidosis. The high protein diet, one has to be careful. There has been some indications of impaired GFR in women with mild renal impairment. So one has to be cognizant of that. The hyperuricemia can cause gouty arthritis or nephrolithiasis. Inflammatory status, again, there seems to be, over time especially, an increase in the inflammatory response. And one little disturbing thing that I did see is that they have shown in mice that if you continue this low carbohydrate restriction for a prolonged period of time, the fat kind of reappears. Even if you're very good and you do everything, the fat kind of reappears. And this is something that has to yet be studied in human beings. Having said that, I think this table is even more important because the mental and emotional status of the person who's on a low carb diet is of extreme importance. Now, carbohydrate is very flavorful, gives you a lot of sense of satisfaction. So if you're not able to eat carb for a long period of calorie itself is that way. But carb has particular palatability difficulties, affects mood, social relationships. When you're on this diet and everybody's celebrating and you can't, and there are all kinds of things that go along with this, so it's okay in a clinical trial, yes, whether it's possible or not, but when you're looking at long term in a person's life, one has to take all this into consideration. There are also other kind of ethical considerations, and most importantly, there are financial implications. Everything that I've talked about so far, we were exclusively talking about meal replacers. So this is going on to expensive products in the Indian market. All of these are quite expensive, may not be in the budget of the average diabetic Indian patient. So that is something, again, that we as physicians and nutritionists and people talking about reversal should be very cognizant about. And I think I would be very, very aware about the fact that a lot of these people who are pushing reversal have a financial kind of backing to them. And although I have shown you evidence to show that it's possible, there's a lot of things to take into account. So practice points would be that very low calorie diet and very low carb diet both have good effects. It's been shown that they can help you lose weight and help in remission of diabetes. They are safe if they are appropriately supported. That's very, very important. Shouldn't leave the patient as it is. Those with a low carb diet, normoglycemia is possible in the absence of weight loss. However, it is very important to note that this remission goes away, that the minute the carbohydrate restriction ceases. Very low calorie diets are driven by this 15 kg weight loss. Maintenance of this diet is a huge kind of important thing. And both work only in a target targeted population. So who does it work for? Younger duration within 6 years with better glycemic control at baseline, less duration, I said, less medications, males seem to be working better, good insulin secretion, less visceral fat, and importantly, good mental health. However, the effectiveness beyond 2 years is limited, and we don't have too much information in an ethnically diverse population, which brings us finally to our own Indian clusters. Look at the clusters, SID, IROD, SERD, MARD. Will it work for everyone? Obviously, it won't. Already in insulin deficient clusters, it's not going to work. However, there may be use in the other clusters which remain to be seen. So I'd like to conclude by saying that remission of diabetes nutritionally is possible. Both the effects of low calorie and low carb both work. I've told you the pros and cons. It must be discussed in a target group, given as an option, and for whoever it works, even if it's for a period of 2 years, it's going to give you long-term benefit. But one must have support from the doctor, dietitian, psychologist, and an entire team of people working to make this happen. Thank you very much.
Thank you, Dr. Anjana, for the fantastic presentation. Anjali, would you like to give your comments?
Absolutely excellent perspective, Anjana, and a very beautiful collection of evidences to present, to be presented in such a nice way. This is definitely a new thing for us. We are yet to know a lot of things about it. One thing we know surely is that it works. And we don't know how it works, we don't know in whom it works, and we don't know for how long it will work, and whether it will translate into prevention of complications at a later date is something that we have yet to see, because there are a lot of things that we see. The effect of weight on the hyperglycemia is different in different people. And the effect of hyperglycemia on complications is also different in different people. But for sure, I would say that even though the major figures say 50%, 60%, if we talk about usefulness, it is useful in 100% people. Whether we take it to a non-diabetic state as a definition of HbA1c below 6.5, and what is challenging is to maintain this low calorie period for a continuous of 8 weeks. And that is where the challenge comes. What I have seen is the duration of diabetes is more important than the severity of diabetes. Because I have seen newly diagnosed patients with HbA1c of more than 10 remitting better than people who have HbA1c of 8 but a duration of diabetes of 10 years. So I think this is a discussion that I had with Dr. Roy Taylor myself, that the level of hyperglycemia possibly is not as important as the duration of diabetes. But an excellent overview.
Those are brilliant points, Anjali, and things that this is still an evolving field. We don't know enough yet, but I think, and congrats on that study. That was most useful when I was reading it.
It is definitely exciting with the way we are failing in diabetes management.
No, it's useful in a particular, it's possible and it's useful. Now, who we give it for and how, we should not produce any harm. That's the only thing that we need to be cognizant of.
Yeah.
What about the use of this VLCD in pre-diabetic people who are obese? Has there been any work done on that, or what would be your point of view on that?
Yeah, so again, for pre-diabetes, this is something that works, I think, really well, because these are people who don't, so like Anjali was saying, the biggest thing is duration. So that is cut off completely here in those with pre-diabetes. So if you cut the calorie, and most of these pre-diabetes, if they have obesity related to this, and they usually do, then it works quite fantastically. It's easier, it's better, it's more durable. So I think if you target that and actually speaking, in the country, we have a larger pre-diabetic population than we have diabetes. So, you know, rather than chasing that, we can actually target the pre-diabetic population, work these on them, and prevent the progression into diabetes, which I think would be a fantastic thing to do.
Next step, yes.
Yeah.
I have a question. If nobody else has it.
Yes, Shilpa.
We have time. She finished in time.
Okay, so Dr. Anjana, you know that maintaining a low-calorie diet of even 1,000 calories over a prolonged period of time is very difficult. Whether it is pre-diabetes, diabetes, or management of weight, it's really challenging. What is the impact of exercise here? Say you increase your diet from 1,000 to say 1,300 calories, and you give a 300 calorie burnout with exercise. Does the impact remain same? or it changes?
So when we're talking about weight loss, so again, it totally depends on the level of the person. Now, someone who is actively trained, a body that is muscular, trained, healthy, okay, the effect of exercise on the weight loss per se will be less. However, if you have somebody who's obese and sedentary, any degree of exercise that you say is going to be synergistic. Once you add the exercise to the diet, you will have a synergistic effect. However, generally itself, the exercise works much better in the maintenance phase. So like you say, if the calorie goes up a little bit, adding that exercise in the maintenance phase. So in the weight loss phase, I would not actually recommend too much of strength training and all that. I would go more, decrease the exercise, make it more aerobic in that phase, focus on the diet for the weight loss phase. But in the maintenance phase, doing a little bit of aerobic and adding the strength there does have effect in maintenance of the weight. So and what we generally see of people and behavior is that once someone who's doing this will also do that. That's the general, unless there is some other thing. But ma'am, I think beyond all this, the biggest challenge is palatability and maintenance of something like 800 to 1000 calories. When Anjali is done, there was another study also in India, and they did only 1500 calories. In our country, maintaining 800, 600, 500 and all, I don't know for that can be done.
No, it's not our country, it's globally, right? People
No,
but if you're doing a structured program, what we in our
Ayushi got cut.
You can speak from here. Speak from here. Thankfully, we are together.
That's good.
So what we have seen in our experience is that
Anita, a little louder.
we have been able to adhere, get patients to adhere to this because it's for a short period of time. Like it's for 8 weeks or 12 weeks. So if it's a structured program for a short period of time, we find that they do adhere to it. And if you look at Roy Taylor's data, 30% of people who were approached for this kind of a diet agreed to do the diet. So it's in actually it's in the physician's minds that our patients will not agree to do it. If you explain to them that it is for a reversal of diabetes, if 30% of people responded and came into the trial, it means that it is doable because it is short term.
No, that's absolutely true. There is a group of people. So that motivation, that agreement to say that, yes, I will do it. In those people, definitely there is and it should be offered.
Right.
Anjana, I have a question. What about using SGLT2? Because you're going to push some glucose in the urine along with, so you get another 300 calorie loss. So can we use SGLT2 inhibitors along with the low calorie diet and then reach remission and stop the drug? Because by definition,
by definition, you should not be using any of the anti-diabetic drugs to say, even if you're using metformin, you can't use the term remission. That is the overall consensus. Using SGLT2 increases your risk of ketosis. And that is something that you should be aware of. So there is no recommendation right now for using. I understand the theory behind what you're saying, makes sense. But unfortunately, I think the risk of ketosis is already high. And so one must consider that. I would consider, they specifically tell us to stop the SGLT2 when going on to the low-cal diets.
I guess this is a topic which can go on for the day, but because we're short of time, I think, can we wind up?
Thank you. Thank you.
Thank you so much, Anjana. Thank you so much.
It's a pleasure.
Thank you, Latika. Bye-bye.
Thank you.
For the last, thank you so much. And for the last session, I would invite Dr. Arvinda Jagdish and Dr. Vinod Mittal to chair the session and take the proceedings further. Are you there, Dr. Mittal?
Yeah, I'm there. I don't know whether Dr. Arvinda is there or not.
Yeah, I'm here.
So I can, so we can go ahead if I can have the slide of, intro slide of Dr. Shekhar. Yeah, so first of all, good morning, everyone. And it's my proud privilege to be here to chair an important session by Dr. Shekhar. And I convey my thanks, to Dr. Sanjay Agarwal and Dr. Nita. Dr. Shekhar is a former director of Karnataka Institute of Endocrinology and Research, Bengaluru, former professor of medicine, and head of the Department of Endocrinology, Mysuru, and director consultant diabetologist, Apurva Diabetes Foundation. He's been member Governing Council, Mysuru Medical College, member of Governing Council for JSS Medical College, visiting faculty and areas of interest, epidemiology. So many feathers in his cap, and so I would straight away request him to please start his talk on yo-yo dieting, how to manage yo-yo dieters. Over to you, Dr. Shekhar.
Thank you, sir. Can I share my screen, please?
Yeah.
Okay, visible?
Your image is not visible. Your photo picture is not there.
I am a disappearing man. I don't know what happened.
Doesn't matter. It's okay.
Okay. Then we will go further because I was asked to put a background and I have disappeared in the background.
You may not put it. Yeah.
Okay. Now.
So you may discontinue the background, sir.
Yeah.
You may discontinue the background.
Okay. How do I do that? I cannot do it here. It's all right.
Okay.
It's okay. Let's go ahead with this. At the outset, I am very thankful to the IDEC team for this opportunity to share my feelings and understanding of this question for the day. But I'm sure the evidence medicine rather EBM pundits will be a tad bit disappointed with me because I do not have very strong evidence for this. And I'm sure the followers of pseudoscience on social media will be very angry with me. Please bear with me. No conflicts of interest from my side. We'll start here. You all know this picture, right? Once upon a time it happened. I cannot tell you the whole story. This is the story of Wright brothers, who did the first flight the world ever saw. But what happened to them in future or whatever in the next few days or things like that, we do not know much, but this tells us what happened to these Wright brothers when they did it wrong. So I'll be talking about the right and wrong of what is yo-yo diet today. As I was telling you, indeed, it's a jolly ride of scientific evidence, not very strong, and real world eminence, bicycle about the weight loss story, that is the yo-yo dieters or yo-yo dieting. So many things are there. Fad diets, let me upfront give you two concepts here. Fad diets, most plans that promise weight loss within the first week, 2 weeks, I'll assure them it is going to fail. Because even if there is weight loss, the diet itself is difficult to sustain. And my predecessors have fantastically spoken, and you know how Anjana was so emotional about what she wanted to present. And a better way to lose weight is to eat with your health in mind. So fat diets on one end and then healthy eating on the other end would be the balance that we are looking at. How do we do that is the question that we'll see. Vicious diet cycle. You all know diet you start because you're worried, body shaming, so many funny things, psychological, health issues, etc. Start dieting, you decrease your calories, famine response, you lose weight and metabolic rate comes down. The whole story happens like this. It goes back. Once complacency kicks in, oh, I have lost weight, I'm doing well, I have to improve my taste buds, the repeat cycle occurs. Diet cycle is a vicious cycle. This is what we have to understand really. Now, the question asked would be, is it a villain or a scapegoat? As on 2021, August or September, we need to look at dieting, whether it is the villain of the century or it's a scapegoat of all possible scientific discourses and pseudoscience that has been thrown around in the social media. And research has generated so much of controversies over the years, at least for the last 2 decades. And this controversy has spilled over into the public domain. You know, the social media, especially as eating disorders and obesity. And we do not talk much about the so-called obesity, you know, regaining your weight and becoming obese, a little bit more obese than what you were earlier. And eating disorders, because there is the conflict between your psyche and the soul. So the pressing problem, if you ask me, is not dieting itself, but the collision of modern food environment, beautifully brought by my predecessor speakers, with our immutable evolutionary heritage. You know, the thrifty gene, thrifty phenotypes, all those immutable evolutionary heritage that we have carried for thousands of years, that drive us to find and consume food when it is available. So today, 30, 40 years later, when food is so much available and at such less price, we are driven to eat. Dieting is more a scapegoat, if you ask me, than a villain because of these two components. And today, instead of saying going on a diet, it's more fashionable to say I'm eating healthy, even though they are not doing a healthy activity at all. But it's in our nature, human nature, that we need to find questions and find answer to these questions. It's not just finding answer to the questions that are in front of us. It is also to find questions. Researchers, for example, they find questions and they want to try to get answers for that. So it's in our nature. And you know the story, Maha Mantra of weight loss is decrease calories intake. Everybody has spoken. But this is very important. Food intake is a very important component of weight regain after weight loss. Simple concept. You have lost weight. How do you regain your weight that is lost? Food intake. Simple equation. 1 is equal to 1 is equal to 1, things like that. But unfortunately, in the modern societies, a chronically positive energy balance is the norm for many. Chronically, you know, somebody was talking after the physical seminars and whatever, what do we do? You know the story, either lunch or dinner. And caloric restriction, how long has remained a point of contention? You know, you've already said 6 weeks, 8 weeks, 6 months, 1 year, 2 years, intensive phase, maintenance phase. It has remained a point of contention in the realm of science. And as a result, so many diet regimes, food fads have become fashion of the day. I'm sorry to make a statement like this, don't mistake me. And one such is yo-yo dieting. Let's come to the yo-yo dieting component. You all know this yo-yo. I was fascinated 45, 50 years ago when I saw the first yo-yo. My uncle brought it from Singapore. I didn't know how to use it. Now everybody knows about it. And this is it, yo-yo. You know the story. Most of you have used it. At least the younger generation have known about it.